Since the last 20 years, many papers have been published on this subject because the prognosis of CML has completely changed with the advent of TKI therapy. Patient now can focus normal life expectancy, and it's natural that a younger patient would start to think about planning and having a family. The use of TKI during pregnancy is precluded for female patients because TKIs are teratogenic and embryotoxic, while they are not genotoxic or oncogenic. For this reason, male patients that are treated with TKI should be kind of safe in conceiving, and there are registries that are trying to harvest cases in a larger number to confirm that. The largest study was published by Zach et al. It recalled 450 patients treated with different TKIs, male patients treated with TKIs, conceiving and the follow-up of the pregnancy are reported, and problems were commonly described as the general population. There were less than 3% abnormalities that are following the normal general population abnormalities. While female patients should not take TKI because of their teratogeneity. This means that TKIs must be stopped at first pregnancy test, and people should not be treated with TKI during pregnancy. To harvest information about that, a registry has been set in Italy through GMEMA, and another larger registry has been set through European Leukemia Net. The first registry has accounted approximately 200 patients, both male and female, while the second one that harvests worldwide patient population is directed only to female patients and accounts of up of 400 pregnancies. What we have found from the literature, from studying embryology and pharmacology, and from the registry information can be summarized in 3 points. The first point is that TKI should be stopped at the first pregnancy test because the first 3 months of TFR are the one in which most of the relapses occur. Those are also the period during organogenesis is formed. For this reason, you don't have to take TKIs. Thus, if you stop at first pregnancy test, you can probably save those first 3 months from having the need of restarting treatment. While if you stop and then you try to conceive, it's not certain that you can conceive right away or that you can relapse maybe when you're pregnant already, and this could be a problem. The second point is that tumor burden is important in deciding starting therapy, and also in understanding at the beginning of a pregnancy if you will restart the therapy at some point during the pregnancy period. Most of the information comes from registry, and you know that Imatinib can be administered after the placenta is formed because it's a TKI that has a limited placental crossing, and there are approximately 55 cases described both with GMEMA and ELN treated with Imatinib after the 16th to the 20th week of pregnancy with an unremarkable outcome. Nilotinib also has limited placental crossing. For this reason, also Nilotinib could be carefully administered during pregnancy after placenta is formed. Dasatinib, on the contrary, should not be administered at any point during pregnancy because other than being teratogenic during the organogenesis period that is between the 5th and the 10th week of gestation, it also crosses the placenta and can give many problems on the homeostatic equilibrium of the baby. For this reason, it should never be administered during pregnancy. Bosutinib, we have 16 cases published of pregnancy in female patients, all unremarkable. All the patients were stopping therapy at first pregnancy test, and we don't know anything about crossing the placenta, but being the structure similar to the dasatinib, we believe that it could cross the placenta, and for this reason it should be discontinued throughout all the pregnancy. Ponatinib, only few cases have been described, and we don't know anything, and for this drug also we suggest not to be taken during pregnancy. And not forget interferon. Interferon is an older drug that was used for a chronic myeloid leukemia patient before the advent of the TKIs. It has been used in pregnancy not only in myeloproliferative diseases, meaning thrombocythemia vera, polycythemia, myelofibrosis, other than CML, but it has been used also for hepatitis or multiple sclerosis patient. We know that interferon has a big molecule that doesn't cross the placenta, and it acts through at the protein level. It doesn't interact with DNA. It's a cytotoxic drug, but not through cell lysis and DNA interaction. For this reason, it can be used during pregnancy, and at any time, also during the first trimester, because it doesn't have any teratogenic or malformation potential. The third thing important is correct monitoring, because if you have the possibility to have a timely results, you can decide if you need to start therapy or not. For example, the kinetics of relapse during pregnancy seems to be different of the kinetics of relapse during the regular TFR, probably because many immunological mechanisms will take place during pregnancy, and we have seen also patients that were stopping treatment and going down with the transcript during pregnancy and rising up after delivery. For this reason, a correct monitoring is suggested. The challenges in managing a pregnancy during CML are present not certainly for people that are planning a pregnancy, they stop treatment and they can maintain TFR, but for patients at onset, for example, that discover CML at onset, or for patients that do not have criteria for TFR and have been treated for a longer period of time. So they mainly don't have a deep molecular response and will probably relapse kind of shortly after the interruption of the drug.